hospital's reasoning is due to the shortage of organs. It chooses patients with the greatest chance of survival. But what's the situation like in South Africa? Can anything like this ever happen in this country? Well, critical care physician Professor Guy Richards joins me now for that conversation. Prof, before we get to the conversation about, how a situation like this would likely play out in South Africa, let's start with a broad reaction on your side. I mean, I saw the story playing itself out in Boston. The man does need a heart transplant, but the hospital is simply standing its ground and saying that, well, simply because you've not been vaccinated, there's a battery of immunizations that we need to make sure that you've taken, and they do include this COVID-19 vaccination. And if you haven't, tough luck. And it's a similar policy in many other hospitals in the US. What have you made of that entire situation?
Well, good afternoon. So if we take a step backwards and we say, well, now, why has he actually refused the vaccine? It's initially a completely ridiculous situation. He, with heart disease, is significantly at risk for the worst forms of COVID now. This is pre-transplant. And in addition to that, he's prepared to accept somebody else's heart into his body. And he's also prepared to accept the multiple toxic immunosuppressive medications that one has to administer in order to ensure that he doesn't reject the heart that he actually gets thereafter. So it makes absolutely no sense that in the first place that he's refused the vaccine. If we go on from there and we then say, well, hang on, if he gets the heart transplant and he's on immunosuppressive medications and he therefore will not be able to form antibodies to COVID, then you will understand why they have suggested that he needs to have the vaccine before he starts the immunosuppressive medication. Because patients who have had transplants and are on these immunosuppressive medications are particularly at risk, because if you vaccinate them after you start the immunosuppressive meds, you are then not going to get the same antibody response that you would do if your immunity was still intact.
So, Prof, let's bring it closer to home then. If I was your patient and lying on your bed and I wasn't vaccinated, and you were making a calculation about, who gets the heart in a situation where the organ transplant needs to be done, and there are all sorts of calculations about the availability of organs, etc., etc. Would it be your calculation that Thulasizwe Simelane, who refuses to be vaccinated because I'm worried about possible side effects of the vaccine, and that's really my only reason for it? Are you saying to me, Professor Guy Richards, that you wouldn't operate on me?
I almost certainly wouldn't, because of the fact that the likelihood of you then contracting COVID afterwards, when you are unvaccinated, have no antibodies, and now are immunosuppressed, would dramatically increase the chances of you dying. And in our setting, we have even less organs available from a transplant point of view, and you therefore have to pick those people that are most likely to survive following the actual transplant procedure.
Sure. But what about that whole, and I don't know if we're blackmailing you with it, but we always like to remind you, the Hippocratic Oath that you guys take. What about that, that commits you to doing the very best for your patient? I'm your patient. Regardless of the choices I've made, whether they're good or bad, I'm still your patient.
You are still my patient, and I would manage you as best as I possibly can. But in the setting of limited resources, we then need to do the best we can for the largest number of people. And in order to do that, we need to pick those people most likely to survive and therefore most likely to benefit from the transplant procedure. And that really has been the case. So, for example, if you needed a liver transplant and you were an alcoholic and you were still drinking, we would not give you that liver. We would give it to somebody else who's not an alcoholic. So again, you are going to pick that patient who is most likely to survive the procedure, and therefore the money that you spend is going to be spent in the best way possible, such that we don't deplete resources unnecessarily.
So a lot of this is still pixelating into focus the law around mandatory vaccines. We've just been talking about the situation in the workplace, etc., and whether a person can be expelled from work for refusing to take the vaccine, but also the discussions of the medical ethics around questions such as the ones that we are posing, you and I, this afternoon. From the conversation we've just had, I get a sense that it's not far-fetched that pretty soon a situation like this could arise in South Africa. What are the parameters? What are the guidelines? Are they similar to the considerations that you and I have just been discussing in the United States?
Well, it's possible. Currently, transplantation has been reduced significantly because of the load on beds already in the intensive care unit. So those planned procedures have actually been limited anyway at this stage. As far as the likely transplants that would be performed, those perhaps that would be most likely at the moment would be lung transplants in people who've had COVID, or it would be in people who've had chronic renal failure and then require a new kidney. So in that setting, I would foresee, in much the same way as we would only transplant those people who would not then compromise the survival of the organ by avoiding the cause of the organ dysfunction in the first place, or by not taking the vaccines and the other immune type boosters that would prevent the loss of that patient and the organ as well. So in each setting, there are different criteria that are placed there for eligibility with regard to vaccine. At the moment, if you're being admitted into hospital, I'm being admitted into hospital already for a procedure myself on Monday. But for that to be admitted for that procedure, I will have to be vaccinated, and in addition to that, I will have a COVID test. And that only makes sense because I potentially would contract the illness whilst in hospital, which is another risk for the patients who are having a transplant, much more than mine because they are actually immunosuppressed as well. And the likelihood, therefore, would be that I potentially, if I contracted it, could send or transmit it to other people in the environment. So I think it is something that is likely to become prevalent with regard to all organ transplantation. This has not been something that up till now has really been relevant or considered, although most of the vaccines that are administered after you or pre a transplant have never been questioned prior to this point. It's just because it's COVID and the anti-vaccine community has become so vociferous that suddenly the administration of the COVID vaccine is an issue, whereas the administration of all the other vaccines, the hepatitis vaccine, the varicella vaccine, the measles vaccine, etc., that you would have before a transplant, have never been questioned prior to this event.
All right. No, Prof, thank you for your time and your insights, and I do hope that it's nothing serious, the procedure that you're going in for, and I hope it all goes well for you on Monday. Professor Guy Richards there, what a time to be alive. A lot of these medical ethical questions that many specialists in the field didn't think would come into sharp focus as they are coming into sharp focus at the moment. Various other sectors as well also considering their responses to these questions around vaccination, the question of choice, whether you're going to take the vaccine or not, mandatory vaccine policies, etc., etc. A lot of these discussions are now front and center in a very decisive way.